welcome to the deep dive. Today we are taking on, well, a pretty monumental task, mastering the entire landscape of cardiovascular assessment and function.
It's a big one.
It is. We're basically going to shortcut a foundational textbook chapter. We want to distill all the core concepts, from the microscopic action potential all the way to the invasive complexity of the cath lab.
And our mission here is really to transform what can be a very dense body of knowledge into something high yield, something you can actually use, actionable clinical insight.
And this isn't just, an academic exercise. It is a clinical imperative.
Oh, absolutely. Cardiovascular disease is still the leading cause of morbidity and mortality. I mean, when you think about it, 121.5 million American adults, that's nearly half the population, live with some form of CVD.
That number is just staggering.
It is. So the ability to perform a rapid and, an accurate cardiovascular assessment is, well, it's arguably the single most critical skill for any nurse. Doesn't matter what your specialty is.
Right. So we've structured this deep dive logically. We'll kick things off with the foundational anatomy and the mechanics of the pump itself, the plumbing and the wiring, so to speak. Then we'll move into the clinical realm, the critical health history, learning to recognize those telltale symptoms, and then the detailed hands-on physical exam, which includes the often tricky world of auscultation.
And finally, we'll wrap it all up by decoding the complex diagnostic tools, the labs, the advanced imaging, and the really critical care components of hemodynamic monitoring.
The goal is, by the end of this, you should be able to synthesize all these different parts into one unified assessment strategy.
That's the plan.
Okay, let's unpack this engine of perfusion, starting right at the beginning with the structure. When we're talking about the layers of the heart, it's so important to understand their function, not just, memorize their names.
Exactly. So the inner lining is the endocardium. What's crucial here is that it's continuous with the blood vessels, and it also forms the structure of the valves.
So any inflammation there could directly impact the valves.
Directly. Then you have the workhorse, the myocardium, that's the muscular layer, and it's responsible for all the pumping action, the contraction.
And on the outside?
The exterior layer is the epicardium.
And all of that is wrapped in the pericardium, that fibrous sac. I remember it has two layers, right? The visceral and the parietal.
It does, and they form the pericardial space. Now, that space is functionally vital, but it's physically tiny. It normally only holds about 20 milliliters of lubricating fluid.
20? That's not much at all.
No, it's just enough. That fluid is like the heart's shock absorber. It reduces friction as a heart goes through systole and diastole.
And the key clinical danger here is what? Tamponade.
Exactly. That's where excessive fluid builds up in that tiny space and literally constricts the heart's ability to fill. It's an emergency.
Okay. Speaking of filling and flow, we have the two major circuits.
Yeah.
Systemic and pulmonary.
Right. The right atrium and right ventricle is dedicated entirely to pulmonary circulation. It takes in all the deoxygenated blood from the body and just pumps it to the lungs.
A pretty straightforward job.
A very straightforward, low-pressure job. The left side, though, that's the systemic powerhouse. It gets all that fresh, oxygenated blood from the lungs and has to pump it through the aorta to the rest of the body.
And the difference in the muscle of the two ventricles really tells that story, doesn't it?
Yeah.
Why is the left ventricular wall, 2 to 3 times thicker than the right?
It's purely about afterload, or the resistance it has to push against. The right ventricle only has to contract against the low-pressure pulmonary system. I mean, it's an easy, short pump.
Right.
But the left ventricle, it has to overcome the high resistance of the entire systemic circulation, the aorta. It just requires massive muscular power to achieve that, hence the extreme thickness.
And that brute force action is what gives us the apical impulse, the PMI, that little pulsation you can sometimes feel.
Yes. That's the movement created when the contracting ventricle twists and sort of strikes the chest wall. You can typically feel it at the fifth intercostal space, left midclavicular line.
And if that impulse has shifted?
Well, if you feel it shifting, say, further down or more to the side, that's your first non-invasive clue that the left ventricle is probably enlarged.
Okay, so the valves. They're the one-way traffic controllers, and when they fail, that's when you get murmurs and heart failure. Let's start with the atrioventricular, or AV, valves, the mitral and tricuspid.
These valves are so unique because they have these active tethering structures, the papillary muscles and the chordae tendineae.
Like little parachutes.
Exactly like parachutes. They're open during diastole, so the ventricles can fill. But the second systole begins, those muscles contract, the chordae pull taut, and that ensures the valve leaflets snap shut completely.
And that prevents backflow or regurgitation into the atria.
Correct.
It's an incredible mechanism, but, I mean, when that mechanism fails, like if the papillary muscles rupture after a heart attack.
Oh, that's instant, acute, life-threatening heart failure. You lose that closure mechanism completely. It's a catastrophe.
And what about the semilunar valves? The aortic and pulmonic?
They're a bit simpler. They open during systole for ejection and close during diastole, and it's all based purely on pressure gradients. When the pressure in the great vessels drops, the blood tries to flow backward, and that fills the cusps and just snaps them shut.
Okay, here's where we get to the heart's unique vulnerability. Its own blood supply. Unlike pretty much any other muscle, the heart feeds itself during its rest phase.
That's right. The coronary arteries are perfused primarily during diastole, so during ventricular relaxation.
Not during the squeeze.
No, during the high-pressure squeeze of systole, blood flow through them is largely choked off. It's only when the ventricle relaxes and the pressure drops that blood can really rush into the coronary arteries.
So if heart rate increases significantly, let's say a patient becomes tachycardic, what's the immediate consequence of that?
If the patient's heart rate goes over 100 beats per minute, the amount of time the heart spends in diastole shortens dramatically. There just isn't enough time for good myocardial perfusion.
So it starts to starve itself of oxygen.
It does. Even in a healthy heart, this is stressful. But in a patient who already has coronary artery disease, this rapid rate will quickly precipitate myocardial ischemia. It's a mechanical timing issue that translates directly into an oxygen debt for the heart muscle.
Now let's move over to the electrical side. We have to remember that these specialized electrical cells have three key properties: automaticity, excitability, and conductivity. Let's trace that impulse.
Okay, so it all starts at the sinoatrial node, the SA node. That's the primary pacemaker. And it sets the rate at a normal 60 to 100 beats per minute. It fires, and that stimulates the atria to contract.
And then the impulse travels to the atrioventricular node, the AV node.
Right, which acts as the gatekeeper.
And the AV node introduces that critical slight delay.
That delay is a protective mechanism. It's so important. It ensures the atria have fully contracted and given that atrial kick to fill the ventricles before the massive ventricular contraction starts.
And the AV node has a backup rate, right?
It does. Its backup rate is about 40 to 60 beats per minute. So if the SA node fails, the AV node can take over.
But if the AV node also fails, you're in real trouble. The Purkinje fibers down in the ventricles take over, but their rate is really slow.
Oh, very slow. We're talking 30 to 40 beats per minute, which is barely sustainable. That's why SA node failure is a big problem, but failure below the AV node is an impending crisis.
Let's touch on the cardiac action potential. We don't need to list every single phase, but let's focus on the really clinically crucial parts.
Okay, let's focus on two things. First is the phase 2 plateau. This is caused by calcium ions slowly entering the cell, which balances out the potassium that's leaving.
And what does that plateau do?
It prolongs the action potential. This is what prevents the heart from just twitching or going into sustained tetanus like other muscles can. It ensures the muscle has time to fully contract and then fully relax, which makes the heart an efficient pump.
Okay, and the second critical part is the refractory period, specifically the relative refractory period.
Yes. This period happens right near the end of repolarization. The cell is mostly recovered, but it's still a little vulnerable. A stronger than normal electrical stimulus can trigger an early premature depolarization.
And that's where the danger lies.
That is the danger. If that happens, especially if the myocardium is already stressed or ischemic, it can easily trigger life-threatening arrhythmias like ventricular tachycardia or fibrillation. Protecting the heart from premature stimulation during this vulnerable window is key to preventing sudden cardiac death. #tag eCardiac hemodynamics and output.
So everything we've talked about, the electrical firing, the mechanical movement, it all culminates in the cardiac cycle and ultimately cardiac output. We already mentioned the importance of that atrial kick.
And that 15 to 25% boost in ventricular volume from the atrial contraction is so vital, especially when the ventricles are stiff or failing.
So if you lose that kick, like in atrial fibrillation,
You immediately compromise your cardiac output.
which brings us to the formula. Cardiac output, or CO, is just stroke volume multiplied by heart rate. Normal is what, about 4 to 6 liters per minute?
That's right. And the body tightly controls heart rate through this balance of the sympathetic system, catecholamines acting on beta-1 receptors, and the parasympathetic system, which is the vagus nerve.
And this whole control system relies heavily on the baroreceptors.
It does. They're located in the aortic arch and the carotid arteries, and they're basically pressure sensors. If your pressure suddenly spikes, the baroreceptors increase their signaling, which triggers a parasympathetic vagal response. Heart rate drops, BP drops.
And if pressure plummets?
The opposite happens. Sympathetic response kicks in, raising your heart rate and blood pressure to compensate.
This is why we see that instability when someone stands up too fast, or why sudden pain can make someone faint. So let's drill down into stroke volume. It's governed by three main factors. Let's start with preload.
Preload is the degree of stretch on the ventricular muscle fibers right at the end of diastole. It's when the heart is at its fullest point. We call this the Frank-Starling law.
Right, which says that up to a certain point, the more you stretch the fiber,
The stronger the resulting contraction and the greater the stroke volume.
So what are some clinical things that can manipulate preload?
Well, anything that alters your circulating blood volume, so diuresis, dehydration, or blood loss, will all decrease preload.
And the opposite.
Aggressive foveate fluid administration or blood transfusions, those will increase preload.
Okay, the second factor is afterload.
Afterload is the resistance the ventricle has to overcome to eject blood. For the left side, we call that systemic vascular resistance, or SVR. For the right side, it's pulmonary vascular resistance, PVR.
And the relationship here is inverse.
Exactly. Increased afterload, like from high blood pressure, forces the heart to work harder, which actually decreases the stroke volume. So medications that lower SVR, like vasodilators, reduce afterload and improve stroke volume.
And the final piece of the puzzle is contractility.
This is the inherent force of the myocardial contraction, and it's independent of preload and afterload. It's enhanced by things like catecholamines or positive inotropes like digoxin.
And what suppresses it?
Conditions like hypoxemia, acidosis, or medications like beta blockers.
And all these factors, preload, afterload, contractility, they determine the ejection fraction, or EF.
Right, EF is just the percentage of the total blood in the ventricle at the end of diastole that gets ejected with each beat. Normal is about 55 to 65%.
And if we see an EF below 40%.
That is the definitive physiological marker of decreased left ventricular function. It tells you there's a significant risk for heart failure. #F age and gender considerations.
Before we jump into the assessment piece, let's just acknowledge that this whole system changes over time. What are the key shifts we see in older adults?
Well, the heart just doesn't respond as quickly or as robustly to demand. The conduction system slows down, which reduces the maximum heart rate you can achieve. The ventricular walls get thicker hypertrophy, which can reduce the chamber volume and decrease the efficiency of contraction.
And the valve.
The valves stiffen, which is why murmurs become much more common.
So the practical outcome of all this is that the older adult has severely delayed compensation.
That's the key takeaway. If they get stressed, dehydrated, or sick, their heart just takes longer to mount a counterresponse.
And this delayed compensation is why their initial symptoms are often so vague, right? Like fatigue or shortness of breath instead of classic chest pain.
Exactly. Unusual fatigue, sudden shortness of breath, palpitations, those are the classic signs in the elderly.
And gender differences are also crucial, especially when it comes to recognizing symptoms and treatment.
Oh, absolutely. Historically, estrogen provided a cardioprotective shield for women. It delayed the onset of CAD by about 10 years compared to men.
How does it do that?
Well, estrogen increases the protective HDL cholesterol, it reduces the harmful LDL, and it promotes vasodilation. But post-menopause, that protection vanishes.
And the risk accelerates.
It accelerates sharply. Sometimes it even overtakes men's risk profiles. We also have to remember that women generally have smaller hearts and narrower coronary arteries, which can make invasive procedures more technically challenging.
Okay, moving from the theory right to the bedside. The nurse's first, and I'd argue most critical role in taking a history is recognizing the acute threats, the symptoms of an evolving acute coronary syndrome or worsening heart failure.
Recognizing the pattern of symptoms, especially those subtle or atypical ones, is truly a matter of life or death. It prevents dangerous delays in treatment. We're looking for the obvious things like chest pain, pain radiating to the jaw, neck, back, or arms, dyspnea, or sudden peripheral edema.
Let's really focus on those atypical symptoms, especially in women. This feels like a massive learning gap we need to close.
I agree. While a man might present with that classic, substernal crushing chest pain, a woman may only report profound, unusual fatigue, we call it vital exhaustion, or nausea, anxiety, or pain that's localized mainly to her jaw, neck, or back. And it often happens at rest.
So because of this nonspecific presentation, we just have to have a higher index of suspicion.
A much higher index. We have to ask about the full range of possible symptoms, not just the textbook male presentation. #B, differentiating chest pain.
All right, chest pain. It's the most frequent symptom, but it's also the least specific. We have to assess it systematically using those classic characteristics.
Yeah.
Quantity, location, quality, radiation, associated symptoms, precipitating events, duration, and relieving factors.
Yes, and when you're interpreting what the patient tells you, the nurse has to hold on to three crucial caveats. First, location does not reliably correlate with the cause.
Right. Substernal pain could be cardiac, pulmonary, GI.
All of the above. Second, severity does not predict seriousness. A benign esophageal spasm can be rated a 10 out of 10, while a life-threatening MI might only be a moderate 4 out of 10.
And what's the third caveat?
That multiple conditions can coexist and really complicate the picture. A patient might have chest pain from ischemia, but at the same time develop shortness of breath from flash pulmonary edema, and then feel palpitations from an arrhythmia that was triggered by all the stress.
So you have to assess everything holistically.
You really do.
So let's compare. How does angina or ACS pain differ from the pain of, say, pericarditis?
Okay, so angina is often described as pressure, squeezing, or heaviness. It's usually relieved by rest or nitroglycerin. Pericarditis, which is inflammation of that fibrous sac we talked about, causes a sharp, severe substernal pain.
And the key differentiator.
It's characteristically aggravated by taking a deep breath or coughing, but it's often relieved by sitting upright and leaning forward. That position takes the pressure off the inflamed tissue.
And what about the dreaded esophageal pain mimic?
Yes. Esophageal spasm or reflux can feel sharp and burning, and it can closely mimic cardiac pain. But it's typically relieved by food or antacids, which helps differentiate it from ischemia. #C. Risk factors, medications, and lifestyle.
Okay, moving into the context of the patient's life.
Yeah.
We separate the non-modifiable risks, age, gender, heredity, from the modifiable risks, which is where we really focus our education and interventions.
Right. Those modifiable risks, smoking, hypertension, high cholesterol, diabetes, obesity, inactivity, those are the pathways we can actually change. We have to assess them aggressively.
Medication history is so important, not just the prescriptions, but also over-the-counters and herbals. And we really have to emphasize adherence to dual antiplatelet therapy, DAPT.
Oh, DASPT is non-negotiable. It's typically a combination of aspirin and a P2Y12 inhibitor like clopidogrel, and it is absolutely required after a stent placement or bypass surgery.
What happens if they miss doses?
Missing doses puts the patient at an extremely high acute risk for stent thrombosis, which can be fatal. The nurse also needs to be assessing for those common GI side effects and bleeding risks that come with all antiplatelets and anticoagulants.
And when we assess nutrition, it has to be quantifiable.
We need objective markers. A BMI greater than 30 is obesity, but even more crucial is that abdominal fat accumulation, a waist circumference over 40 inches for men or 35 for women.
At centralized fat storage.
It's very strongly linked to CAD. We also track their lipid panel, of course, distinguishing between that protective HDL and the cholesterol-depositing LDL.
Let's talk about elimination. The patient's report here can actually hold some critical clues about their fluid status.
Nocturia is a classic, often missed symptom of heart failure. Fluid that pools in the legs during the day gets reabsorbed into the circulation when the patient lies flat at night.
Increasing the circulating volume.
Right, which causes the kidneys to excrete the excess. We also have to caution patients about the Valsalva maneuver. Straining during defecation can temporarily raise intrathoracic pressure, which can trigger a profound vagal response.
Leading to bradycardia and syncope.
Exactly. #TED, D-sleep, activity, and psychosocial factors.
Activity tolerance is really the functional barometer of the heart, isn't it?
It really is. Any new or changing symptoms, angina, dizziness, shortness of breath that occur at a previously tolerated level of activity is a major red flag for myocardial ischemia or worsening heart failure. It demands immediate investigation.
And symptoms of worsening HF often show up at night, affecting sleep and rest.
They do. We look for orthopnea, the need to sleep propped up on multiple pillows or even in a chair, and the acute crisis of paroxysmal nocturnal dyspnea, or PND.
PND is that sudden awakening, gasping for air.
Yes. It's caused by the rapid reabsorption of fluid from the periphery into the lungs when the patient lies down. It's a rapid shift in preload that triggers pulmonary congestion.
And a huge, often missed risk factor that happens during sleep is obstructive sleep apnea.
Untreated OSA, characterized by loud snoring and daytime sleepiness, is strongly associated with cardiovascular risks like hypertension, atherosclerosis, and atrial fibrillation.
Why is that?
Well, the intermittent hypoxemia and the sympathetic surges just put continuous stress on the entire system, and it's critical. If the patient uses a CPAP or a mandibular device, they must bring it with them to the hospital.
The psychosocial impact of chronic CVD is just immense. How do things like self-perception and stress factor into a patient's prognosis?
A diagnosis like an MI or HF can easily lead to depression and anxiety. And unfortunately, depression is twice as prevalent in women, and it consistently correlates with poorer prognosis and medication non-adherence.
Patients who feel overwhelmed are less likely to stick with the program.
Exactly. If they perceive their illness as uncontrollable, they're much less likely to maintain those vital lifestyle changes.
And the AHA actually recommends formal screening, starting with the PHQ-2 tool.
Yes. If a patient scores a 3 or higher on those two initial questions about interest or hopelessness, they should move to the full PHQ-9 for a more targeted assessment and a referral for intervention. We can even quantify stress with tools like the Social Readjustment Rating Scale.
Finally, we need to talk about sexuality. This has to be a proactive conversation, not a reactive one.
It really does. Sexual dysfunction is common, often affecting twice the rate of the general population. This can be due to fear, depression, or side effects from medications.
But the activity itself is generally safe.
Sexual activity is generally low-intensity exercise. The nurse has to be the one to initiate this discussion, reassure the patient, and facilitate a referral to a cardiac rehab program for specialized counseling. And for women, always remember that a history of preeclampsia is a long-term CVD risk factor that needs to be documented.
All right, let's move to the hands-on portion, starting with those initial visual clues and the general appearance.
The very first observation is their level of consciousness and mental status. Are they alert and oriented? Lethargy or confusion can be a critical sign of inadequate cerebral perfusion from low cardiac output or even a stroke.
And then just looking for obvious distress.
Obvious distress, anxiety, acute shortness of breath. And we confirm their risk profile by calculating their BMI and measuring their waist circumference. #B skin and extremities.
The extremities are really the early warning system for perfusion status. Let's run through the signs of acute arterial obstruction, the 6 Ps.
These signs demand immediate attention. They are pain, pallor, pulselessness, paresthesia, that's the tingling or numbness, poikilothermia, which is coldness, and paralysis.
This is a critical check, especially after something like a cardiac catheterization.
Oh, absolutely. Acute occlusion of the artery they used is a feared complication.
Now, what about the chronic signs that might point to an underlying insufficiency?
Chronic arterial insufficiency shows up as hair loss on the legs, brittle nails, skin atrophy, and those characteristic round, deep, pale, or black ulcerations.
And venous insufficiency looks different.
It does. It usually presents with more superficial, irregular ulcers and something called stasis dermatitis.
Okay, capillary refill time. That's our rapid assessment tool.
We press the nail bed and measure the time it takes for the color to return. Normally, it should be less than or equal to 2 seconds. A prolonged cap refill indicates compromised arterial perfusion. It's a hallmark finding in low cardiac output states like cardiogenic shock or decompensated heart failure.
And edema. How do we standardize this, since it can be so subjective?
We use a standardized scale for pitting edema, which is common in HF or peripheral vascular disease. It ranges from absent or 0 to trace, which is a 1+L, all the way up to severe, a 4+L, which is an indentation of an inch or more.
And it's important where you assess for it.
Crucial. You have to assess dependent areas. So the feet and ankles in patients who are walking around, and the sacrum in patients who are bedridden or immobile. #C, blood pressure and pulse evaluation.
Blood pressure gives us the mechanical context. We define normal BP as less than a 120/80. Stage 1 hypertension starts at 130 to 139 over 80 to 89.
And the pulse pressure, the difference between the systolic and diastolic, gives us immediate insight into stroke volume and systemic resistance. Normal is about 40 millimeters of mercury.
So what does a narrow pulse pressure tell you? Let's say it's 90/70, so pulse pressure of 20.
A narrow pulse pressure means the systolic pressure is low relative to the diastolic. It often signals that the body is severely vasoconstricting to compensate for a very low stroke volume.
Like in shock or severe heart failure.
Exactly. The vasoconstriction, the high diastolic, is trying to maintain mean arterial pressure, even though the heart can't pump enough volume, the low systolic. A wide pulse pressure, on the other hand, signals a high stroke volume, often seen in fever or aortic insufficiency.
Let's detail the procedure for an orthostatic hypotension assessment because it's so directly linked to fall risk.
Okay, this is mandatory, especially if the patient is on antihypertensives or diuretics. You start with the patient lying supine for 10 minutes. Then you check their blood pressure and heart rate while they're sitting after about 2 minutes. And then you check it again while they're standing immediately and then again at 3 minutes.
And a positive result is?
A positive result is a sustained decrease of 20 millimeters of mercury or more in their systolic pressure, or 10 or more in their diastolic within 3 minutes of standing.
And this is often caused by reduced preload, dehydration, or that failure of baroreceptor compensation we talked about earlier.
Exactly. When those baroreceptors fail to signal that rapid sympathetic increase upon standing, blood pools in the extremities, preload drops like a rock, and the blood pressure just plummets.
Okay, now assessing the arterial pulses. We have to check the rhythm, and we need to remember that normal variant of sinus arrhythmia in young adults.
Right, that's the benign rhythm, where the rate just slightly increases with inhalation and slows with exhalation. More importantly, though, if you find an irregular rhythm, you must check for a pulse deficit.
And how do we do that?
This requires 2 people, or 1 person, simultaneously counting the apical heart rate for a full minute, while also palpating the radial pulse.
And the pulse deficit is the apical rate minus the radial rate. Why does this happen, say, in atrial fibrillation?
Well, in AFib, many of the ventricular beats are so premature that they produce an insufficient stroke volume. There's not enough volume to generate palpable pulse wave all the way out at the periphery, even though you can hear the beat at the apex. A significant deficit tells you the cardiac function is inefficient.
We standardize pulse amplitude using that 0 to +4 scale, which, even though it's subjective, it gives us some consistency.
Right. 0 is absent, +1 is weak or thready, +2 is normal, and +4 is bounding. Always document the site and the scale you're using. And if a pulse is absent, you have to immediately use a continuous wave Doppler to confirm if there's flow.
And we assess pulse contour best over the carotid artery.
Yeah, you can feel for subtle differences there. A feeble, slow-rising pulse often signals aortic stenosis because of the reduced ejection volume. A rapidly rising and falling pulse, the water hammer pulse, is a classic sign of aortic insufficiency.
And the essential safety alert during palpation?
Never palpate both the temporal and carotid arteries at the same time. You risk occluding blood flow to the brain, which could cause syncope or a stroke.
Finally, we estimate central venous pressure, or CVP, non-invasively by looking at the jugular venous pulsations, the JVP.
Right. We observe the internal jugular veins with the head of the bed elevated somewhere between 45 and 90 degrees. Obvious distension that persists high up the neck indicates an increased CVP.
And since CVP is the filling pressure of the right atrium.
Distension is a primary indicator of hypervolemia or right-sided heart failure. This finding can confirm the volume overload you might have suspected from their history of PND and edema. #BBAD, precordial inspection and palpation.
So we conclude the hands-on assessment by systematically inspecting and palpating those 6 areas of the precordium. What are the abnormalities we're looking for?
The location and characteristics of the PMI are key. If that apical impulse is displaced, or if it occupies 2 or more adjacent intercostal spaces, that strongly suggests left ventricular enlargement. We also palpate for a left ventricular heave or lift. That's a broad, forceful thrusting sensation.
And the thrill.
A thrill is a palpable vibration. It feels like a purring sensation over an area of turbulent blood flow. This finding is always serious. It's only associated with loud, high-grade murmurs, grade 4 or higher, and it points directly to severe valvular disease or a septal defect.
Auscultation. This is where the nurse truly synthesizes the mechanics and the electrical timing. Let's start with the 2 normal heart sounds, S1 and S2.
S1, the lub, is the simultaneous closure of the mitral and tricuspid, the AV valves. It marks the beginning of systole and it's loudest at the apex.
And S2.
S2, the dub, is the closure of the aortic and pulmonic, the semilunar valves. It marks the end of systole and it's loudest over the base of the heart.
So the period between S1 and S2 is systole. Between S2 and the next S1 is diastole. And sometimes we can hear a physiological split S2.
Yes. Normal splitting happens on inspiration because the increased venous return delays the pulmonic valve closure just slightly. The key is that the split disappears on expiration. If the splitting is constant, it's abnormal and usually indicates some pathology. #B, abnormal heart sounds. Gallop, snaps, clicks.
Okay, the presence of an S3 or an S4 gallop is one of the most important clinical insights we can get from the physical exam. Let's break down the S3 gallop first.
The S3, which sounds like lub-dub DUB, is heard early in diastole right after S2. It's the sound of blood rapidly rushing into an already volume-overloaded, non-compliant ventricle.
And while it can be normal in young people.
In an older adult, an S3 is highly indicative of heart failure due to volume overload. If your patient reported PND or has edema, finding an S3 pretty much confirms your suspicion of decompensated HF.
Okay, and the S4 gallop.
The S4 sounds like LEB lub-dub, and it's heard late in diastole just before S1. It's generated by the atrial contraction forcing blood into a non-compliant, stiff ventricle, often one that's hypertrophied from chronic hypertension or coronary artery disease.
So S4 is pressure problem, and S3 is a volume problem.
That's a great way to think about it. S4 signals high pressure and stiffness, while S3 signals volume overload.
And if both are present, especially with tachycardia, they can merge into a summation gallop. We also listen for those high-pitched valve sounds, opening snaps, and systolic clicks.
Right. Opening snaps are abnormal diastolic sounds caused by the high-pressure opening of rigid stenotic AV valves, like in mitral stenosis. Systolic clicks are associated with the opening of calcified semilunar valves or the prolapse of the mitral or tricuspid valves during mid to late systole.
And finally, murmurs, the sound of turbulent blood flow. We have to be so meticulous in describing them using those 6 factors: location, timing, intensity, pitch, quality, and radiation.
The most critical factor for the nurse to identify is the intensity, which is graded from 1 to 6, and the single most important threshold is grade 4.
Why is grade 4 so important?
Because a murmur that's graded 4 or higher is defined as being loud, and it's associated with that palpable thrill we just discussed. Finding a thrill in a grade 4 murmur immediately signals severe underlying structural disease that requires urgent intervention.
And what about the sound that's often mistaken for a murmur? The friction rub.
A friction rub is a harsh, grating, scratching sound that you can hear during both systole and diastole. It's caused by the inflamed pericardial layers rubbing together, a classic sign of pericarditis. You hear it best with the diaphragm while the patient is leaning forward. Hashtag C. Assessment of other systems, lungs and abdomen.
Cardiac issues rarely stay contained within the heart.
Right.
What are we listening for in the lungs to confirm that fluid is backing up?
We listen for crackles. They signal fluid accumulation in the alveoli, and they typically start at the bases because of gravity. A dry, hacking cough is also really common with pulmonary congestion related to HF.
And the emergency side.
Pink, frothy sputum. That is an emergency indicator of acute pulmonary edema.
And the abdomen often confirms right-sided failure.
It does. Right ventricular HF causes increased CVP, which leads to venous congestion sledemically. This can result in abdominal distension, ascites, and potentially an enlarged liver and spleen.
And we can use the hepatojugular reflex test to help confirm that.
Right, by pressing firmly on the right upper quadrant. If that causes a sustained increase in the JVP of 1 centimeter or more, that helps confirm heart failure.
Reduced urine output is another red flag, signaling inadequate renal perfusion due to low cardiac output.
So we have to assess immediately. If the urine output is low, the first thing we do is check for bladder distension. Is the problem systemic hypoperfusion, or is it just a mechanical retention issue? Assessing the bladder is a critical first step before you escalate your concern about low CO.
Moving on to diagnostics. Laboratory tests are absolutely indispensable for diagnosis, risk stratification, and monitoring. The cornerstone for any acute diagnosis is the cardiac biomarker.
Troponin T and troponin I are the most specific and sensitive biomarkers we have. Their elevation confirms myocardial necrosis cell death from ischemia or trauma. They are the primary tool for diagnosing a myocardial infarction. Hashtag blood chemistries and special biomarkers.
Let's focus on the 2 electrolytes that are the primary drivers of arrhythmia risk: potassium and magnesium.
This is so critical. Hypokalemia, low potassium, is incredibly pro-arrhythmic. It risks life-threatening VTach and VFib, and it makes digitalis toxicity much worse.
But high potassium.
Hyperkalemia risks complete conduction failure, heart block, and a systole. And magnesium is often overlooked, but hypomagnesemia must be corrected as it risks both atrial and ventricular tachycardias.
Calcium plays a slightly different role.
Yeah, calcium is more about contractility and nodal function. Hypocalcemia can impair contractility, increasing HF risk, while hypercalcemia can potentiate digitalis toxicity.
And we also monitor BUN and creatinine, which reflect renal perfusion.
Right. An elevated BUN and creatinine suggests reduced renal blood flow, which is a proxy indicator for low cardiac output. Or it could be a sign of dehydration from overdiuresis.
Let's discuss the risk factors revealed by the lipid profile, which requires that 12-hour fast.
We categorize cholesterol by its function. LDL, the low-density lipoprotein, that's the bad cholesterol. It transports cholesterol into the arterial walls, causing plaque.
And HDL?
HDL, high-density lipoprotein, is protective. It scavenges cholesterol away from the tissues and brings it back to the liver for excretion.
Two specialized biomarkers are crucial for diagnosis and risk assessment, BNP and hsCRP.
Right. Brain natriuretic peptide, or BNP, is a neurohormone that's secreted by the ventricles when they're stretched by increased preload and volume. A BNP level greater than 100 is highly suggestive of heart failure. We use it for both diagnosis and to monitor how well our treatment is working.
And C-reactive protein, or CRP, tells us about hidden risk.
CRP is a nonspecific marker of inflammation, but we now know that chronic inflammation is a key driver of atherosclerosis. We use the high-sensitivity hsCRP test. A level of 3 milligrams per liter or greater indicates the highest risk for future cardiovascular events, even in patients who might otherwise seem low risk.
And we also look at homocysteine.
Yes, this is an amino acid that's been linked to endothelial damage and plaque formation. Elevated levels, 15 or higher, are an independent risk factor for CAD and stroke. #be electrocardiography, ECG, and monitoring.
The 12-lead ECG is the universal tool. It can diagnose everything from arrhythmias to electrolyte disturbances.
And continuous ECG monitoring or telemetry is standard for any high-risk patient. Crucially, these systems monitor the ST segment. ST depression signals myocardial ischemia. ST elevation signals an evolving infarction.
Okay, here's a critical quality and safety alert.
Yeah.
What is the nurse's primary caution regarding ECG monitoring?
The monitoring system only detects electrical changes. It does not detect symptoms. Patients often assume that the machine will alert the nurse if they're having chest pain or shortness of breath.
And it won't?
It will not. The nurse must explicitly tell the patient, you have to report any change in your symptoms immediately, regardless of what the screen shows.
And the ongoing problem of alarm fatigue requires some specific nursing interventions to minimize false alarms.
The focus here is on the interface between the skin and the electrode. This means meticulous skin prep clipping hair, not shaving, debriding the skin, ensuring good contact, and changing those electrodes every 24 hours.
And we also prioritize specific leads, right?
Yes. We use lead 2 for optimal P-wave visualization, so for atrial activity, and lead V1 for ventricular activity and arrhythmia diagnosis. And finally, individualizing the alarm parameters like turning off the rate alarms for a stable patient in AFib is essential to making sure nurses respond promptly to the true alarms. #C, stress testing and imaging.
Cardiac stress testing helps us evaluate the heart's function under periods of controlled increased oxygen demand, which can help us identify flow blockages.
In an exercise stress test, the patient walks on a treadmill toward a target heart rate while we monitor their ECG, blood pressure, and symptoms. Nursing preparation here is key. They need to fast for several hours, avoid stimulants like caffeine, and we often have to hold rate-slowing medications like beta blockers for up to 48 hours to make sure their heart rate can increase fully.
And for those patients who can't exercise, we use pharmacologic stress tests.
Right, we use agents like adenosine or regadenosin. They're potent vasodilators that mimic the effects of exercise by forcing maximal coronary artery dilation. This shows us where blood flow cannot increase, which indicates a stenosis.
And there's a crucial nursing intervention with these.
Yes. Patients must refrain from all caffeine and chocolate for 24 hours beforehand because they interfere with the effects of these vasodilating agents.
We often combine the stress test with myocardial perfusion imaging, like SPECT or PET, to actually visualize the flow.
This imaging technique compares blood flow at rest versus blood flow during stress. And this is where we get a really critical clinical distinction.
A fixed defect versus a reversible defect.
Exactly. A fixed defect, where flow is absent both at rest and during stress, indicates an old myocardial infarction, dead tissue. A reversible defect, where flow is reduced only during stress but it normalizes at rest, that indicates ischemia.
And that distinction guides treatment.
Completely. A fixed defect may not benefit from revascularization, while a reversible defect is the primary indication for bypass surgery or stenting.
And advanced imaging like CT and MRA can add even more structural detail.
Right. Coronary CT angiography gives us high-res images of the coronary arteries using contrast, but we have to be really cautious with patients who have renal insufficiency because of the risk of contrast-induced nephropathy, or CIN.
And with MRA.
MRA uses magnetic fields, so that requires rigorous screening for any metal implants, and you have to remove any transdermal patches that have aluminized layers to prevent severe burns. #D echocardiography.
Echocardiography is the non-invasive gold standard for measuring ejection fraction, chamber size, and valve function.
The transthoracic echo is the standard. If the images from that are inconclusive, or if we need a clearer view of the posterior structures, we'll proceed to a transesophageal echocardiography, or TE.
Now, a T is more invasive. It requires sedation and is threaded down through the esophagus. What are the key nursing safety measures after a T?
Well, since the throat is anesthetized, the patient has to be NPO for 6 hours before the procedure. Afterwards, the primary safety intervention is protecting their airway. We monitor their level of consciousness and their SpO2 closely, and we must ensure their gag reflex is fully intact before we allow any oral fluids.
And that usually takes how long?
It usually requires withholding fluids for at least 2 hours to prevent aspiration.
All right, cardiac catheterization. This is the definitive invasive procedure for both diagnosis and intervention. It's categorized into right and left heart caths.
A right heart cath assesses the pressures and oxygen saturations in the right atrium, the ventricle, and the pulmonary artery. A left heart cath is more common. It uses contrast to perform coronary angiography to evaluate the patency of the coronary arteries and ventriculography to assess left ventricular function.
And this is high risk, especially the risk of contrast-induced nephropathy.
CIN risk has to be managed aggressively, especially in patients with diabetes or chronic kidney disease.
And prevention focuses on hydration.
Yes. We administer pre- and post-procedure 5E saline hydration to help flush the contrast from the kidneys, and we monitor their creatinine levels very closely.
The post-procedure care really hinges entirely on the access site, radial versus femoral.
The radial approach is now highly favored because it's associated with fewer complications and allows for much shorter bed rest. A compression device, like a TR band, is used and then gradually deflated over about 2 hours. But the nurse still has to assess for specific risks like radial artery occlusion or compartment syndrome.
And the femoral approach requires much stricter management.
It does. For femoral access, where they use large sheaths, hemostasis requires manual pressure, mechanical compression, or vascular closure devices. This means 4 to 6 hours of absolute bed rest with the affected leg immobilized and kept straight.
And the head of the bed has to be kept low.
No more than 30 degrees, this is critical. Maintaining this low elevation minimizes strain on the puncture site and reduces the risk of bleeding, hematoma, and the catastrophic risk of a retroperitoneal bleed, which is a life-threatening, often hidden complication.
What's the post-procedure monitoring cadence?
It's very intensive. Vital signs and peripheral pulse checks must be done every 15 minutes for the first hour, then every 30 minutes for the second hour, and then hourly for the next 4 hours. And you're constantly comparing the affected and unaffected extremity for those 6 Ps, checking for early signs of arterial compromise like pain or numbness.
And managing the inevitable vasovagal reaction.
Yeah, that sudden onset of bradycardia, hypotension, and nausea. It's usually triggered by discomfort or even a full bladder. The immediate nursing actions are critical. Elevate the patient's legs above their heart, give an IV fluid bolus to rapidly restore preload, and be ready with atropine if the bradycardia persists. #hemodynamic monitoring, the critical care view.
For the critically ill, we move to hemodynamic monitoring, which gives us continuous, direct measurements like CVP and PA pressures. And accuracy here is everything.
Accuracy depends entirely on proper leveling and zeroing. The single most important landmark is the phlebostatic axis. That's the intersection of the fourth intercostal space and the mid-axillary line.
And the transducer has to be at that level.
The transducer stopcock must be placed exactly at that level, regardless of the patient's position, as long as the head of the bed is elevated 60 degrees or less. This ensures the pressure reading accurately reflects the level of the atria.
And we also need scrupulous attention to system maintenance and infection control.
Preventing catheter-related bloodstream infections, or CRBSIs, is a major quality initiative. We adhere to a strict care bundle. Meticulous hand hygiene, cleansing the site with chlorhexidine, using chlorhexidine-impregnated dressings, and scrubbing all the ports before and after every single access.
You treat every access like a sterile procedure.
Every single one.
Let's look at the key measurements. CVP monitoring reflects right ventricular preload.
Right. Normal CVP is 2 to 6 millimeters of mercury. A CVP greater than 6 strongly suggests hypervolemia or right-sided HF. A CVP less than 2 suggests hypovolemia or dehydration. This number directly validates the fluid status you suspected from your JVD assessment and their history.
Pulmonary artery, or PA, pressure monitoring is complex but crucial for assessing left ventricular function and shock states.
This requires a specialized balloon-tipped catheter. The most important readings are the PA diastolic and the PA wedge pressures, which give us a surrogate measure of left ventricular filling and preload.
And there is an urgent safety alert regarding that PA wedge reading.
Yes. When you're obtaining the wedge pressure, the balloon should be inflated for a maximum of 15 seconds. The nurse must immediately ensure the balloon is fully deflated and verify the return of the normal PA systolic-diastolic waveform on the screen.
Because failure to deflate risks.
Pulmonary infarction or rupture, which is catastrophic.
Finally, intra-arterial blood pressure monitoring. This gives us direct, continuous BP readings, typically through the radial artery.
But before we insert that arterial line, we have to assess the collateral circulation, usually with the modified Allen's test. This test confirms that the hand can be adequately supplied by the ulnar artery alone. If blood flow restoration takes longer than 7 seconds, the radial artery site should not be used.
Because cannulation risks distal ischemia.
And potential tissue loss if that radial artery occludes. #C. Minimally invasive CO monitoring.
Given all the complexities of the PA catheter, minimally invasive technologies are becoming more popular alternatives for estimating cardiac output.
They are. They rely on techniques like pulse pressure analysis, which estimates stroke volume from the existing arterial pressure waveform. Now, while they're easier, these systems require an optimal signal and may not be accurate in patients with significant arrhythmias or hemodynamic instability. We also use things like esophageal Doppler and CO2-based FIC methods to provide estimates without a full PA catheter insertion. #outro.
We have completed a really comprehensive tour, moving from the microscopic mechanism of the heart's self-feeding cycle, that crucial diastolic perfusion, all the way to the critical care management of invasive monitoring. I think the real mastery comes from synthesizing all these pieces. When you encounter a patient, you're not just listing symptoms or reading numbers. You're constantly connecting the dots.
Absolutely. You have to remember the critical interplay between the mechanics and the electricity. When you see that EF is below 40%, you know that mechanical failure is driving an increased arrhythmia risk. When the patient reports PND and you find that S3 gallop and their CVP is greater than 6, you are seeing the entire Frank-Starling curve pushed to its absolute extreme.
It's a sign that their maximum compensatory effort has failed.
It's failed due to volume overload. That synthesis, understanding why the body is failing and how to intervene, that is the definition of expert assessment.
That is really powerful. So we discussed the baroreceptors, the pressure sensors that reflexively increase heart rate and peripheral vasoconstriction when BP drops, that fast compensation you need when you stand up. Now consider an older adult experiencing orthostatic hypotension because of impaired, sluggish baroreceptor function. They stand up, their BP drops, and their body fails to rapidly compensate. How might this failure to stabilize impact their safety when they're simply getting out of bed? And what is the single most urgent nursing action required upon recognizing this decline?
The failure to compensate leads immediately to profound cerebral hyperperfusion, which results in dizziness and syncope. The immediate clinical consequence is a very high risk for falls and injury.
And the most urgent nursing action?
The single most urgent nursing action is to reverse that hypoperfusion by restoring their preload. You have to rapidly elevate the patient's legs above the level of their heart, administer an IV fluid bolus, and be prepared to give atropine if bradycardia persists. You're manually supporting the circulatory system that their own baroreceptors failed to support.
A perfect demonstration of translating complex physiology into immediate, life-saving action. Thank you so much for joining us on this deep dive into cardiovascular assessment.